Long. Can you hear me, Long? Can you just give
Yes,
me a shout? Oh, okay,
yes,
that's great.
I can hear you. So yeah, thanks a lot, Dr. Majid, for taking the time to give this very valuable and useful talk. I'm just checking whether this thing, the live streaming, whether it's synchronized well or not. Hang on.
I think it is because I have got Facebook open on my
Okay
other
then.
screen. Yes.
Because it doesn't show on my mobile phone. Okay, yeah, without further ado, it give me great pleasure to introduce Dr. Majid Ali. Okay, Dr. Majid Ali, after being graduated with Master of Science in Clinical Pharmacy from University College London in the UK in 2007, started his career as a researcher and has been a project manager for developing, implementing, and evaluating diabetes pharmaceutical services in community pharmacy setting in the UK. Dr. Majid as well was associated with the School of Pharmacy, University of Hertfordshire for 10 years as a senior lecturer. During his tenure, he was the winner of several academic awards for his teaching skills, including the very prestigious Vice-Chancellor Tutor of the Year in 2012, as well as the Faculty Excellence Award in Blended Learning in the same year in the University of Hertfordshire. In 2014, he was also awarded with financial grants for developing an educational mobile phone apps for the UK pharmacy students. Currently, he is working with Al Quran University at Mecca, Saudi Arabia, and into his 5 years of service there. Dr. Majid has a special research interest in pharmacogenomics, as well as using simulations and artificial intelligence in pharmacy education and practice. So I would like to stress also that he is an associate fellow of higher education academic in the UK. And in 2018, Dr. Majid was awarded with the honorary adjunct fellowship from University of Adelaide at Australia. He is also a board certified geriatric pharmacist, BCGP, from the Board of Pharmacy Specialties and the board certified advanced diabetes manager from American Associations of Diabetes Educator. Okay, without further ado, I pass the screen back to Dr. Majid Ali. Thank you very much.
Okay, thank you very much, Long, for the introduction. And it's a great pleasure to be speaking about diabetes management in Ramadan. And thank you, Long, for pushing me to do that. Long has been really working hard behind the scenes to make it happen. And I've been very lazy and elusive, but finally it's happening. I've just noticed that maybe the slides are lagging behind a little bit on the Facebook Live, but I think it should be okay. Okay, so if there is a problem and my voice is not synchronized with the slide changing, please shout out in the chat on the Facebook. So let's get into this. So some key points before we start the actual management. Majority of the people, we know from our practice and we know from the evidence as well that most of the people, most of the diabetic patients who are advised not to fast in Ramadan, they fast anyway. Our job as healthcare professional is to help them fast safely, so we can advise them how to manage their medications, how to manage the other health conditions, how to manage their hypo or hyper if they get it. Patient-centered approach becomes more important to help. We always talk about patient-centered approach. So this is where it becomes most important. You will see that how much individualized the care has to be when we manage diabetes for individual patients. So as I said, the personalized approach is the key. So on your slide, you can see one of the tables which I have taken from the IDF, International Diabetes Federation slide, IDF guidelines. IDF, if you don't know IDF is International Diabetes Federation, and they have a just released 2021 guidelines about how to manage diabetes in Ramadan. That was just released in January this year. So this so a lot of information I have taken from those slides. So this is how this gives you an idea how the management of diabetes should be individualized based on individual patients. You can see that there are a lot of factors involved. For example, Ramadan-related factors. So Ramadan-related factors. In various countries, the length of fasting varies, for example, from 14 to maybe about 19 hours. Season of fasting, whether it's a summer season or a winter season, geographical location, and social changes. Type of diabetes the patient has, duration of diabetes, diabetic complications, and then anti-diabetic therapy. All of these should be taken into account when we individualize the treatment plan for the diabetic patient. And then, of course, the age, the gender, the occupation becomes very important, pregnancy and the meal patterns, and the exercise nature and timing, and of course, how much motivated the patient is to make the change in their lifestyle. So let me introduce two cases to you, and then we'll go into the management. So this is a case number one, 21-year-old student. She has type 1 diabetes for the last 12 years. Recent HbA1c 8.9%. Wish to fast in Ramadan. She comes for the consultation 2 months prior to Ramadan, and she is currently taking glargine insulin 24 units bedtime, and Lispro, which is rapid-acting or short-acting insulin, 7 units with each meal. So she's on basal bolus regimen. No DK in the last 4 years, and she experiences early AM and early PM hypos. Case number 2, 45-year-old female teacher, so the occupation to be noted, with type 2 diabetes for 10 years. She's currently on Humalog Mix 25, which is a mixed insulin. 40 units in morning and 40 units in the evening, and she's also taking Genumet, which is a combination of metformin and sitagliptin, twice daily. Last HbA1c was 7.6%, BMI 29, and she also on treatment dyslipidemia. So for both the cases, we need to consider whether we should recommend the patient to fast or not. And then if recommended, what counseling or what education we need to give to these patients based on their characteristics they have. And then how many times we should advise them to monitor their glucose when they are fasting in Ramadan, and how would we adjust the doses of their medications. So these are the things need to be addressed when we approach these two patients. So we will see if we have time in the end, we'll come back to these cases. So these are the two references which you can see on your screen. One on the right side of your screen is the Diabetes and Ramadan Practical Guidelines 2021 guidelines from IDF, which I was just talking about. They were just released in January. Very, very, very comprehensive guidelines. It's a more than 300 pages guideline. So it has got a lot, everything you need to know about diabetes in management in Ramadan. And basically this is majority of the authors of this guidelines are from the MENA region, like from the Middle East region. So, but they take into account of the South Asian background as well. The other reference which you can see on the left side of your screen is the recommendations for the management of diabetes during Ramadan from ADA and EASD consensus. So this from the American and the European Association consensus. So again, it's another very, very, very useful resource of guidelines. So alongside that, we are going to send you the copy of these slides later on, and we'll try and send you the PDF version of these resources as well. So majority of the information on these slides you will find have been taken from these two resources. So just some stats. Over 100 million Muslims are there. Over 100 Muslims worldwide have type 2 diabetes. 1.6 billion Muslims there are in this world at the moment, which constitute about 23% of the population, and roughly estimates to be more than 100 million patients with diabetes. Right. So 8.8% of the population estimated to have diabetes, and out of which 90% of them have type 2 diabetes. 80% of the people with type 2 diabetes fast in Ramadan, and 40% of the type 1 diabetes patients. We have got these numbers from the studies in the Middle East, that 80% of the type 2 diabetes fast, and 40% of the type 1 diabetic patients fast. And as I said before, that you will see later on that a lot of patients who we advise not to fast, they still end up fasting, because they consider fasting as they consider Ramadan as a very, very, very important religion, from a very important month from the Islamic point of view, and they do not want to miss fasting in that month. So what are the risks of fasting when diabetic patients fast in Ramadan? There is a risk of severe hypoglycemia. And there is a risk of severe hyperglycemia as well. You might be thinking that when they are not eating anything, how could hyperglycemia occur? Yes, we know from the studies there are a lot of hyperglycemia cases as well. Number one is there when the patients are not fasting, when the patients are fasting, then gluconeogenesis and glycogenolysis still happen in their body in response to not eating anything, and then that can increase the blood glucose levels. Also, in Ramadan, when the patients have the evening meal, which is called iftar, when they have that evening meal, they tend to eat a lot of sugary stuff, and that can lead to hyperglycemia as well. Then, of course, dehydration, and this depends a lot on the country where you live in and the weather. So especially in the Middle East countries, dehydration is a lot problem, whereas in the UK, dehydration is not much of a problem because the weather is generally not very hot. So thrombosis. Thrombosis is have also seen with dehydration in the studies. The other two things which I would add to this is glycemic variation. So you see a lot of variations in glucose levels throughout the day in diabetic patients, and that can be very harmful for them. The other thing I would add is the weight gain. So we have a few studies which showing that diabetic patients actually end up having a weight gain at the end of the Ramadan. And as I said, that when the fast finishes in the evening, and when they have the evening meal, which is iftar, they tend to eat a lot, and that might they tend to eat a lot of unhealthy stuff, and because of that, they might end up having weight gain at the end of the Ramadan. So I would add these two things to this slide: glycemic variation throughout the day, and also the weight gain. Now, how important fasting is for Muslim people in Ramadan? It's ordered in Quran, and it's a lot of emphasized, and you can see the reference for that on the screen. So because it's ordered in Quran, so and that's why the Muslim patients take it very seriously to fast in Ramadan. But there are exceptions. The Quran also says that the people, if it is difficult to fast, then it's not recommended for fasting. And also in reference to some other verses in Quran which says that do not, which translate roughly to that do not harm your own body. So if the diabetic patient is in a situation that if they fast and they're going to that, then it's recommended for them not to fast. The other situations in which they are exempted from fasting are listed on the slide, which include the travelers, the children, the menstruating females, those who are acutely or chronically ill. And when we say acutely ill, that also includes COVID-19. So at the end of this webinar, we have some points we will discuss about diabetic patients who are fasting in Ramadan in relation to this COVID-19 pandemic as well. So in short, it's strongly recommended in Quran for the Muslim people to fast, and that's why they take it very religiously. But there are exemptions for the people who should not fast, and those people who should not fast include pregnant. There's option for pregnancy, but the travelers are also exempted from fasting. Menstruating females must not fast as well, and those people who are acutely or chronically ill, and if they are going to fast, they're going to harm their health. It's recommended for them not to fast. So just quickly, the pathophysiology of feeding. So pathophysiology of fasting, you can see on the left side of the screen that when you are not fasting and when you eat food, there is insulin secretion, and which inhibits gluconeogenesis, and it stimulates glycogenolysis, which stores glucose in your body. But when you're fasting, there is no glucose, there is less insulin secretion, and less insulin secretion stimulates gluconeogenesis from the liver, and it inhibits glycogen stores depletion. So the glycogens, there is gluconeogenesis and the glycogenolysis, so the glycogen stores decrease. But when the diabetic patient fast, the difference is that no glucose leading to less insulin secretion stimulates gluconeogenesis, plus it stimulates ketogenesis as well, especially in type 1 diabetic patients, so they're at greater risk of having ketoacidosis. And also it inhibits the glycogenolysis stores depletion, and there is excessive breakdown of glycogen in them. So what happens in Ramadan? There is a lot of change in the lifestyle of the Muslim patients when they start fasting in Ramadan. Generally, because of the change happening in Ramadan, that they have evening suhoor, which is the morning meal, and iftar, which is called the evening meal. And also there are a lot of differences in the lifestyle based on the geographical locations as well. So for example, when I was in the UK, the normal working life continues when the Ramadan comes every year. So the Muslim people have to adjust their lifestyle according to whatever is happening around them. So for example, generally there is no leniency at work. The working hours are the same. And the other things continue. Whereas in Muslim countries, when I moved to Saudi Arabia, there is a lot more change in the there's a lot more change socially here as well. The working style changes, the working hours are reduced to up to 6 hours in some places, and some of the working places are closed during the day. They open at night, and literally the day and night are reversed. Almost everything is closed during the day, and at night things are open in Ramadan. So there is a lot of changes there's a lot of things happening in Ramadan. There is frequent increase in food intake and some weight gain, which I've already talked about. Food type is likely to be more sweet and oily, and there is activity decreases, especially I'm talking about in the countries like Saudi Arabia, where the working hours are officially reduced. So result in decrease in the physical activity as well. Sleeping pattern changes as well, and people tend to sleep more during the day as compared to the night. And those people who have diabetes and when they're fasting, they have a fear of hypoglycemia. And because of that, they tend to change or decrease the doses of their medications on their own without any medical advice. And this can lead to a worsening of the diabetes. So this is how the pattern changes in Ramadan. You can see that in non-Ramadan, that's the normal routine. You have a breakfast in the morning, you have lunch in the afternoon, dinner at night, and then you sleep generally sleep at night. But in Ramadan, you can see that the people are awake in the morning time, and then they take. Let's start from here. So they are up early in the morning, very early in the morning, before dawn, to eat suhoor, which is the morning meal. So again, the morning meal needs to be eaten before the dawn breaks. So that is very early, and then the people tend to sleep after that a little bit, and then they're awake in the late morning, and then the afternoon comes, and then they're likely to take the afternoon nap, and then they wake up in the late afternoon. They're awake late afternoon, and then they have the iftar meal, and then some people sleep and some people do not sleep. Like in Saudi Arabia, people generally tend not to sleep at night, and they until they have suhoor in the morning. So you can see that how much the Ramadan routine is varied from the outside Ramadan life, and as I said before, that it also depends on the geographical location where you're living. That also affects the people's lifestyle. So what happens to the fasting, the glucose levels, how much they fluctuate during the day in diabetic and non-diabetic patients? So your first graph you can see on your screen is from the people without diabetes. So you can see that there is, and the red line is when they are fasting. So you can see that there is some fluctuation in their glucose levels at around fasting, and especially around the iftar time, the evening time. And there is much more fluctuation if the patient has diabetes. So they are more likely to have hypo just before the evening meal, and they are more likely to have hyper just after the evening meal when they have eaten. So pre-Ramadan diabetes education should focus on 7 key areas. Again, this has been taken from the IDF guidelines. This has been taken from the IDF guidelines. The 7 key areas which should be focused on is the risk quantification or the risk stratification, which means that you look at the patient condition, how much the duration of the diabetes the patient has had, how well controlled this patient's diabetes is, and what other comorbidities this patient has. Based on all those conditions, you do the risk stratification, and you do the risk stratification, and you identify whether this patient is a high risk, moderate risk, or low risk. And there's a lot of guidance about that, which we will go through in a minute in the next few slides. So how to stratify the patient's risk. Then we advise the patient how many times they should monitor their glucose based on, again, what type of diabetes they have, and based on medications they are taking, and based on their previous experience. Then we should also give them advice about the fluid and the dietary advice. I've got a lot of information in the later part of the slide about nutrition, but I will not go through all of them because they're quite detailed, and we'll send a copy of that slides to you later on. How we should advise the patients to do the physical activity, how much, that should be included in the education as well. And of course, the main part, as we are, I guess majority of them of here are pharmacists. So the majority of our focus is on the medication adjustments. The most important thing is to advise the patients when they should break the fast, when it's harmful for them, when they should break the fast. And we need to make sure that the patient recognize the hypoglycemia and hyperglycemia symptoms, because that will tell them when to break the fast. So we start assessing the diabetic patient, whether they should fast or not. We should do that at least 6 to 8 weeks before Ramadan. We are a bit too late, as Ramadan is starting in maybe 3-4 days, but it's never too late. But ideally, we should assess the diabetic patient for fasting in Ramadan 6 to 8 weeks before the Ramadan starts. And the reason for that is if we need to make any changes in the treatment, we can make the changes in the treatment, and then we can see how the patient is getting on that treatment before Ramadan. If it is too late, like this time, it is generally not recommended to make any major changes in the medication just before Ramadan, or especially we should not start some drugs. For example, GLP-1 agonists are strongly not recommended to start just before Ramadan. SGLT2 inhibitors should not be recommended to start just before Ramadan. If the patient is already on them for quite some time, that's fine to continue, but they should not be started just before Ramadan. We, from pre-Ramadan assessment, we need a detailed medical history of the patient, and why that will become clear in the next few slides. And I think that's fine. So when we do the risk stratification, which I will show you how to do that in a minute, we figure out whether this patient is a low, moderate, or high risk, and based on that, they are given the advice about fasting. As I said before, that patients are advised on how to and how many times they should monitor the glucose levels as well. The most important thing to bear in mind is to advise patient that when to break the fast, when their blood glucose level is less than 70 milligram per deciliter or less than 4 millimoles per mil. So when their blood glucose is less than that, they should break their fast. Whether symptoms are present there or not, they should break their fast. If the blood glucose levels are more than 300 milligrams per deciliter or more than 16.5 millimoles per liter, with or without symptoms, they should break their fast. So the two conditions I have told you, if there is hypo, and then we have got the numbers for that, less than 70. If they've got hyper, more than 300, they should break their fast with or without symptoms. In addition, if they have symptoms of hypoglycemia or acute illness happening, maybe because of hyper, then they should break their fast, regardless of the glucose level. So if they are feeling hypoglycemia symptoms or they're feeling acutely ill, they must break their fast straight away. I would also include now during this pandemic time, I would also add to this if they start feeling symptoms of COVID-19 when they are fasting, they must break their fast as well, because that comes under acute illness. And then, of course, we need to do some pre or post Ramadan assessment as well, because we all know that after Ramadan comes Eid, and that's the time when people are more likely to eat more sweets and tend to have more hyperglycemia. So they need a post Ramadan assessment as well. So this figure, which you can see on your slide, has been taken from the UK guidelines, and it tells you that which patients fall in high risk category, which patients fall in moderate risk category, and which patients fall in low risk category. And you can see that acute illness is in the high risk category, comorbidities is in patients with comorbidities in high risk category. People with type 1 are generally in high risk category, and if they are tested positive, they are also in the high risk category. So this stratification, which I'm going to talk to you about now, is the pre-Ramadan assessment. So again, this is pre-Ramadan assessment. When you are trying to figure out whether the patient is high, moderate, or low risk category, based on that, you will advise them whether to fast or not. So this is pre-Ramadan assessment. So this is from the UK guidelines. This one has been taken from the IDF guidelines, which is very, very useful. And I have seen the physicians use it a lot here because it quantitatively stratifies the patient's risk. And you can see that there are about 14 items on this list, and the patient is given a score on every item. And based on that, you calculate the patient's score. I will tell you in a minute how to interpret that score. But if you just look at these 14 items on the screen, you can see it includes diabetes type and duration. It includes type and duration. It includes presence of hypo. It includes how well the diabetes is controlled, type of treatment the patient is on. It includes ability to self-monitor the blood glucose. It includes acute complications. It includes renal impairment. It includes other comorbidities and complications, pregnancy, cognitive function, physical labor like physical exercise, prevention, previous experience of fasting in Ramadan, and fasting hours depending on the geographical location. So all these 14 items, the patient is given a score. And if the patient is having 0 to 3 score, then it's a low risk. If the patient ends up having 3.5 to 6, it's a moderate risk, and above 6 is a high risk. How to advise the patient? Low-risk patients are given a green signal that fasting is probably safe for them and they can go and fasting, but still we need to give them education and counseling on other issues and manage their medications when they're going to fast. The people who are moderate risk are in the orange light, and this fasting is uncertain for them. They're advised that they should not fast, but if they want to fast, they can. And still, again, medical, they should be given, if they decide to fast, then they should be given the full education, Ramadan education and counseling, and their medication should be managed. The people who have high risk, they are advised not to fast. They must not fast. And sorry, just give me a sec. They must not fast. But we have seen that the people who are in moderate risk and high risk categories, they end up having fasting as well, even against the medical advice. So if, as a pharmacist, you come across a patient who is even a high risk patient, and he is insisting on fasting, of course, we cannot stop them from fasting. If they still insist to fast, it's their choice, but it's our duty to highlight that they have a risk. And also we should advise them about we should give them all the education on hypos, how to recognize hypos and hypers. We should help them adjust their medications. And most importantly, we should tell them when they should break their fast. Monitoring of blood glucose. There are, in the IDF guidelines, 7-point guide is recommended, like it's 7 times they should monitor the glucose levels. So what are these 7 times? What are these 7 times? If you see, one is just before the suhoor, which is the dawn morning meal, so just before that. One is that maybe 2 hours after that, and the third time is the midday. Fourth time is maybe 2 or 3 hours after that. Fifth is just before the iftar, the evening meal, and sixth is 2 hours after iftar. And the seventh is at any time when the patient feels hypoglycemia or hyperglycemia symptoms. So 7 times seem a lot for some patients. Generally, I have seen what the patients are advised, and that's just that's just based on the observation that 7-point guide is for those people who have type 1 diabetes, and those who are on basal bolus regimen. In contrast to this, there is a 2 to 3 point recommendation. 2 to 3 point means one time just before suhoor, Second time is the mid or afternoon or the late afternoon, because that's the time when they tend to have hypoglycemia. That's around the Asr prayer time. And the third time is after the evening meal. So that's the 2 to 3 time point, and which is recommended for the patients who have type 2 diabetes and for the patients who are on oral hypoglycemics. The patients who are on mixed insulin, now that's a bit of dilemma whether we should put them in 7-point category or 2 to 3-point category. And again, you have to individualize those patients who are on mixed insulins. It depends on the patients. If they are ideally, according to the guidelines, if they are capable, they should do 7-point fasting. But if it's a bit too much for them, then they can opt for a 2 to 3-point monitoring as well. Something about the nutrition. I'm not going to go into a lot of the nutrition because I want to spend more time on the medication management. So I have put a lot of resources on the slides for the nutrition plan, and some of the important references as well, which you can look into. So this has been taken from the IDF guidelines again, and you can see that for the dietary changes, you have to divide the calories between suhoor and iftar. Ensures that meals are well balanced with this, and include a low glycemic index and high fiber foods that release energy slowly before and after fasting. So the dates, which are most commonly used by Muslims in suhoor and iftar, they contain slow release carbohydrate. They have slow release carbs. Include plenty of fruits, vegetables, and salads. Minimize foods that are high in saturated fats. For example, should not take the foods which are fried in the oil, and especially the samosas and pakoras, which are very famous in the Middle East and Pakistan, India, and Bangladesh. Avoid the desserts which are very sweet, and avoid caffeinated and sweetened drinks as well. There is a link which I have given on this slide, which is a very, very useful link. And if you go into that link, that will help you individualize the plan for the patient based on the patient lifestyle, based on the geographical location where you are. So yeah, that's what you will see, that when you go onto that link, and these are the countries, and if you click on the country where you are, that will give you the nutritional plan for your diabetic patients based on the lifestyle there. Generally speaking, this has been taken from the IDF guidelines, and if there are patients who are looking for the weight maintenance, or the patients who are looking for the weight reduction, that's how they should work out their calories. If there is a lot of information about the okay, this is called the nutrition diabetes nutrition. This has been taken from the Ramadhan nutrition app, and the links which I have shown you before, you will find a lot of information on this plate model on those websites based on the country you live in. So as you can see, these tables on your slides, these are just the examples of how the calories should be taken based on the food in those countries. So if it's in the Southeast Asian country, you can follow this. If you are in Arab or in our Middle East countries, you can follow this one. And if you are in the Malaysian side, the Malaysian, Indonesia, Singapore, Brunei, you can follow this column. Exercise advice. Now, the rigorous exercise should be avoided if the people are fasting, the diabetic patients are fasting in Ramadan, especially during the last hours of the fasting, which is just before the iftar or just before the evening meal. The rigorous exercise should be avoided because it may lead to, of course, to hypo or and hydration and dehydration. People with diabetes should also be encouraged to maintain their normal physical exercise during Ramadan. So that's an important point. The other important point is that a lot of the, patients, a lot of Muslims, as they go for the night prayers, they attend the night prayers, which is Taraweeh. And if the patient plans to pray Taraweeh prayers, the nighttime prayers, then that can replace their daily exercise. Because that takes a lot of physical movements, repeated movements in Taraweeh. There are a lot of repeated movements in Taraweeh, so that can replace the normal physical activity. Okay, all individuals should break their fast. I'm emphasizing that again and again. The patients should be reminded and emphasized when they should break their fast. When their blood glucose levels are below 70 milligrams per deciliter, when the blood glucose levels are more than 300 with or without symptoms, and when they feel serious symptoms of hypo or hyper, or they feel severe dehydration, or they feel acute illness, including COVID-19 symptoms. Also make sure that the patients recognize the symptoms of hyper and hypoglycemia. So medication management in Ramadan, that's the crux of the pharmacist specialities. Now, I have summarized the tables which you can see on my slides. They have a summary of all the medications. But if you look at the IDF guidelines, the 2021, you will see that they have got very fancy figures for each category of the diabetic medication. But that basically is the same thing which you can see as a summary on my slides. So let's talk about metformin first. Metformin daily dose remains changed. Now, again, one thing to bear in mind with metformin is that it does not cause hypoglycemia. So the daily dose remains unchanged. The other issue about metformin is that it can cause more problems if the patient gets dehydration. So that's why the normal sick day rules, which I will talk about later on, I'm sure you know about the sick day rules. So that normal sick day rules apply here as well, that if the patient feels acutely ill or severely dehydrated, they should stop metformin. How to adjust the dose? I said the daily dose will remain the change, but you might have to adjust the dose if the patient is taking it 3 times. If the patient is taking once daily, that dose should be taken after iftar. If the patient is taking twice daily metformin, then the morning dose should be taken after suhoor, and the evening dose should be taken after iftar. If the patient is taking 3 times, then the morning dose will be taken at suhoor time. And of course, the patient cannot take the second dose during the day. So that afternoon dose should be combined with evening at iftar. So for example, if the patient was taking 500 milligrams 3 times a day, 3 times a day, then the 500 milligram will be taken after suhoor, and 1000 milligrams will be taken after iftar. So again, the afternoon dose will be combined with the evening dose, and that will be taken after iftar. So that's in the case of if metformin is at 3 times a day. If the patient is on metformin extended release, then simply take that after iftar. Acarbose, no dose adjustments. Thiazolidine generally taken once a day, so no dose adjustment or no modification. The dose can be taken with iftar or with suhoor. Short-acting insulin secretagogues, which means ripaglinide. So these are short-acting, or sometimes you call it short-acting extra short-acting sulfonylureas. So they are generally taken with every meal 3 times a day. So obviously, you're not taking the afternoon meal, so the afternoon dose will be skipped, and the patient will only take 2 doses instead of 3 doses. And out of those 2 doses, one after suhoor and one after iftar. GLP-1 receptor antagonists, once appropriate dose titration has been achieved, no further dose modifications are needed. So generally, if the patient is taking it once a day, that should be taken at iftar time. If the patient is on twice daily exenatide, it is better to move the patient to once daily, but that should be done 6 to 8 weeks before Ramadan. DPP-4 inhibitors, no dose adjustment required. So you can see that okay, let me talk about SGLT2 inhibitors after that. SGLT2 inhibitors also no dose adjustment, no dose modification required. The dose should be taken. It's generally SGLT2 inhibitors are once a day, so they must be taken after iftar. And the reason is that they have a diuretic effect as well. So if the patient is having diuresis, it will be easy for the patient to hydrate as well. So it's advised SGLT2 inhibitors taken after iftar. Extra clear fluid should be ingested during non-fasting periods, because as there are concerns about use of SGLT2 inhibitors when the patients are fasting, because the dehydration can cause problems here. There can be other UTI problems as well. So if the patient is on SGLT2 inhibitors, they are given the advice to take extra fluids when after iftar. Should not be used in elderly patients, renal impairment, and hypotensive individuals, as it can cause postural hypotension as well, and for those taking diuretics. Generally, if the patient is also taking diuretic, and the patient is also taking SGLT2 inhibitor, which we will reduce, we generally reduce the dose of diuretic. So you can see that these are the drugs which I have talked about so far. They do not generally cause hypoglycemia, like metformin, acarbose, thiazolidine, GLP-1 agonist, receptor antagonists, DPP-4 inhibitors, SGLT2 inhibitors. They generally do not cause hypoglycemia. So for these categories of the drugs, we do not change the daily dose, but we might change the timing of the dose. Now, the drugs which cause hypoglycemia, such as sulfonylurea and insulin, their modification is a little bit more complicated, but we'll see. So sulfonylureas, switch to newer sulfonylureas such as gliclazide and glimepiride as compared to glibenclamide, or which is also called glyburide, because they are short-acting, relatively short-acting. So it's better to switch the patient to gliclazide and glimepiride. When you would switch, when you're assessing the patient 6 to 8 weeks before Ramadan. But if it's too late like this time, then it's recommended not to make a switch, and just carry on what the patient is taking. If the patient is taking once daily sulfonylurea, then take at iftar time, and dose may be reduced in patients with a good glycemic control. So if the patient has a good glycemic control before Ramadan and the patient is taking once daily sulfonylurea, the patient should be advised to take that iftar time and reduce the dose a little bit if possible. If the patient is taking BID 2 times sulfonylurea, then iftar dose remains unchanged, and the suhoor dose may be reduced in patients with glycemic control, maybe 20 to 30%. So sulfonylureas, better to use the newer generation sulfonylureas because they're relatively short acting. If the patient is taking once daily sulfonylurea, then that should be taken at iftar, and consider reducing the dose. If the patient is taking twice daily sulfonylurea, the morning dose with suhoor, the evening dose with iftar, and that the suhoor dose should be reduced, but the patient is not going to be eating anything for the whole day, and that might cause hypoglycemia. Insulin therapy. Long-acting insulins, or the basal, long-acting or intermediate-acting insulin, or in other words, basal insulin, if the patient is taking once daily, then if the patient is taking once daily basal insulin, then take it at with iftar and reduce the dose by 15 to 30%. If the patient is taking twice daily basal insulin, then take the usual dose at iftar time. Now, this is a bit complicated. If the patient is taking twice daily basal insulin, then the morning dose will be taken with iftar time, and the nighttime dose will be taken at suhoor time. So this will be reversed. So you do that, and also the dose which you are taking at suhoor time, that should be reduced by 50%. So again, for basal insulin, if the patient is taking once daily, that should be taken with iftar and reduce the dose by up to 30%. If the patient is taking twice daily basal insulin, then you reverse it. Morning dose should be taken with iftar, and the nighttime dose should be taken with suhoor. So that's reverse timing. And the dose which the patient is taking at suhoor should be reduced by 50%. So you can see generally what's happening here is that the doses which the patient is taking in the morning time, we are reducing them because we know that this patient is not going to be eating and drinking for the rest of the day. So we don't want to give the full normal dose with suhoor in the morning time. Rapid acting or short acting insulins, take the normal dose at iftar. Of course, the afternoon dose will be skipped. So you don't take the afternoon dose, and the suhoor, suhoor dose will be reduced again. So again, the same principle applies here, that if it's a rapid acting, short acting insulin 3 times a day, you skip the afternoon dose, and the evening dose will be taken with iftar. The morning dose will be taken before suhoor, but that suhoor dose will be reduced. What about pre-mixed insulin? Now, with pre-mixed insulin, if the patient is taking once daily, you take it at normally at iftar time. If the patient is taking twice daily premixed insulin, then again, take the usual morning dose at iftar. So again, this is reversed like this with the twice daily basal. And basically you do the same thing which you did with the twice daily basal insulin. So the insulin timing will be reversed and the suhoor dose will be reduced. That's with twice premixed insulin. If the patient is taking 3 times premixed insulin, which we don't see a lot, then in that case, of course, afternoon dose will be skipped, and you adjust the iftar and suhoor dose. So that's how you adjust the medication therapy and the insulin if the patient is taking insulin. But this is not the end of the story. We should also advise the patients who are on insulin to monitor, and if they are having high or lows, then we advise them to adjust their insulin doses based on their glucose levels. So that's, you can see how they are advised to adjust. That's mentioned on the slide, and this is also from the IDF guidelines. So I'm not going to go through into the detail, but patient can generally be given a written chart or a paper or a leaflet on which they can be given a written advice on this, that how to adjust their insulin doses based on their glucose levels when they will be monitoring them. Now we see a lot of patients now insulin pumps as well. So if you have a patient who was on insulin pump and he has decided to fast, then we reduce the basal rate in the insulin pump in the last few hours of fasting, which is before the iftar. We reduce the basal dose by 20 to 40%, because that's the time when they're likely to have hypoglycemia. And then after iftar, increase the dose by 30%. So I have seen that the physicians advise to the patients that reduce your basal rate before iftar by 30%, and then after iftar increase it by 30%. bolus rate, no, that again depends on the normal carb counting and insulin sensitivity. So the patients who are put, when they are put on pump, they are given extensive advice about carb counting and how to adjust their bolus rate based on their carb counting, and that the same principles apply here as well. There's nothing different in Ramadan. So whatever carbs they are taking in suhoor and iftar, based on that they adjust their bolus rates. This is a very, very important table. I have taken this from the ADA guidelines about Ramadan. So there's a lot on this. And I would just highlight that this one is based on, this is just the normal recommendation of ADA. So I will not go through into that. I'm sure you know about all of this. The thing which we'll focus on is this part, which is the variation in Ramadan. So I have tried to maximize a little bit on the next slide. And this says that how you adjust the reason I have put this on the slide, because it gives an idea how to adjust the medications based on other medications the patient is taking. So for GLP-1 receptor agonists, it says that ensures patient is stable tolerated dose before Ramadan. And one thing important to it highlights here is that do not initiate GLP-1 receptor agonist as a new medication just before Ramadan. And that's, again, I would highlight that you assess the patients 6 to 8 weeks before Ramadan. And if there is a need, then start it so that you have enough time to see how the patient gets on that, especially because the nausea side effects of the GLP receptor antagonist, but do not start it just before Ramadan. SGLT2 inhibitors continue usual dose during Ramadan as with special advice on hydration. And again, the same advice, do not initiate it as a new medication just prior to Ramadan. Thiazolidinediones and DPP-4 inhibitors, no change is required if the patient is already taking. And it also advises, the ADA guidelines advise stop or reduce sulfonylurea if the patient is also on sulfonylurea, insulin dose if the combination used with DPP-4 inhibitors. So basically what that is saying is that if the patient is on thiazolidinedione or DPP-4 inhibitor, and at the same time the patient is taking sulfonylurea and insulin also, you should decrease sulfonylureas or insulin dose. GLP-1 receptor antagonists and SGLT2 inhibitors, again, the same, I think I've mentioned that before, do not initiate them just before Ramadan. DPP-4 inhibitors, I've mentioned that before, stop or reduce the sulfonylurea and insulin if the patient is on them as well. And I think the rest of them are the same. Yes, sulfonylurea, consider stopping or reducing the dose if appropriate, and basal, I think we have covered that. So there is some useful information from this about how you adjust the doses of other medications if the patient is taking them. This table, again, being taken from the IDF guidelines, and this is about how to adjust the injectable therapy. Basically, the same principles which I discussed in detail about how to adjust the insulin dose. But let's see if they have got anything different. Consider stopping or reducing the dose if experiencing GIT side effects. That's with the GLP-1 receptor antagonists. With basal insulin take with iftar, consider consider once daily dose take with meal iftar time, and reduce the dose, and be twice daily switch the doses and reduce the morning dose by 50%. The same principle which I have covered before with basal insulin. Prandial insulins, which means the rapid acting or short acting insulins, usual maintenance dose with iftar, skip the lunchtime dose and reduce the suhoor dose or morning dose by 50%. Again, the same principle which I discussed that before. And with pre-mixed insulin, it's almost the same, which I discussed with basal insulin. Some very important tables taken from the ADA guidelines. Let's look at the table number 2 first. Recommended changes for insulin therapy for type 2 diabetic patients. If the patient is taking insulin, the sulfonylureas, consider sulfonylurea. Important point which we have not covered before, that if the patient is on sulfonylurea and insulin, consider discontinuing sulfonylurea. For any insulin, try to titrate and establish dose to achieve adequate glycemic control prior to start of the Ramadan, and then in Ramadan accordingly, which we have seen how they will adjust their insulin doses based on the glucose levels when they are monitoring. And once daily dose, I think the same principles are here. If the patient is taking basal insulin once a day or basal insulins twice a day, the same principles of rapid acting insulins and the same principle for pre-mixed insulin. Generally, you will see that pre-mixed insulin dose adjustment is almost the same as the basal insulin dose adjustment. Table number 3 here is the same information which I have shown you before, but it gives more guidance about what to do based on what the levels are. If the levels are more than 300, break the fast. We have covered that before, and increase a daily insulin dose by 20%. That's a new thing here. If the levels are more than 180, then increase the insulin daily dose by 10%. If the levels are between 100 to 180, which should be their normal levels, then there's no change required. If the levels are below 70, break the fast and reduce the insulin dose by 20%. If the levels are below 50, break the fast, stop the insulin, and or reduce the insulin by about 40%. A question for you, and I'm going to give you 1 minute to answer that question, but let me introduce this patient first. A 45-year-old male with type 2 diabetes for 5 years. He comes to you before Ramadan to discuss the appropriate management of his diabetes using Humalog Mix 25, which is the pre-mixed insulin. And this patient is also on SGLT2 inhibitor, 20 milligrams once a day. The dose of insulin this patient is taking is 40 units in the morning and 30 units in the evening. HbA1c is 7%, so it's fairly well controlled. How will you adjust his insulin dose during Ramadan? So based on that, so again, think about this patient is taking pre-mixed insulin twice a day. You have got the number of units. Now, based on that, what would you advise this patient? I'm going to give you 1 minute. If you figure out the answer, please write that in the chat box on Facebook. Thanks to those who are posting their answers. I'll give just 1 more minute. Okay, well done, everybody. This A is the correct answer here. So basically, as we have explained before, the 40 units the patient is taking in the morning, 30 units in the evening. So that will be reversed. So 30 will go in the morning and 40 will go in the evening. And the morning dose will be reduced by 50%. So that will become 15. So 15, that makes 15 units in the morning before suhoor, and 40 units in the evening just before eating iftar. Okay, well done, everybody. So now recommendations for preventing hypoglycemia, because that's the greatest fear of the diabetic patients when they're fasting, how they can reduce that. Depending on the treatment regimen, we have seen that that sulfonylurea or insulin have a more risk of hypoglycemia. Monitor glucose levels daily or several times a day. And I have mentioned that before, that there are 2 models, like 7 time monitoring and 2 to 3 time monitoring, and which patients fall in which category, whether they should monitor 7 times or whether they should monitor 2 to 3 times. Patients treated with insulin should measure glucose before, during, and after. Okay, ignore that point because I've covered that in more details, that if they are on basal bolus regimen, then they should be monitoring 7 times. If they're on pre-mixed insulin, then that should be individualized. If it's easy for them to do 7-time monitoring, then they should do that. If it's easy for them to do 2 to 3 time monitoring, then they can do that. Consultation with diabetes healthcare provider for medication adjustment. Patients should be strongly advised not to make changes in their medications on their own. They must contact or consult their pharmacist for that. Treatment regimen should be evaluated and modified according to the glycemic control or hypo at least 1 month. I said 6 to 8 times according to the guidelines prior to Ramadan. If it's like 3-4 days left in Ramadan, just like this time, it's too late to make or initiate any changes in Ramadan. Avoid or reduce sulfonylureas and or insulin doses. We have seen that before. Avoid skipping pre-dawn meals like the suhoor meal. The morning meal or suhoor must be always taken, because sometimes people have this habit of not eating anything in the suhoor meal. The diabetic patients should be strongly advised against that. They must eat something in suhoor in the morning meal. And we generally advise patients to eat suhoor as late as possible. So for example, if the suhoor time is going to finish at, for example, 5 a.m. in the morning, there are some people who just eat at 3 a.m., like 2 hours before that. So that is not a good thing to do. They should delay their suhoor as much as possible. Avoid vigorous physical activity during fasting, especially if they have a plan to pray the nighttime prayers, the Tarawih prayers, then they should avoid excessive physical exercises. Adjust medications and eat a snack in presence of hypo. We have talked about that in a bit more detail, and they should know when to break their fast, and we have discussed that before. Measure blood glucose levels to determine the patterns contributing to hypoglycemia. If they are having consistent hypoglycemia for 2-3 days, they should document or write them somewhere what levels they're having at what time, so that the doctor or the pharmacist can adjust their medications accordingly. Other important considerations, dietary education and meal planning, very, very important. Again, the very important thing is to advise the patient to take excessive fluid intake, and this should be, I should say, non-sugary fluids after iftar and during Tarawih prayers, because Tarawih is like an exercise for them. So they must take, the people should always be advised to take a bottle of water with them when they're going for the Tarawih prayers, so they can have a sip on them during that. Modification of the time intensity of the physical activity. We have mentioned that before. Emphasize the importance of the blood glucose monitoring, and educate the patients that the during fasting breaking does not invalidate the fast. Now, I will cover that in a bit more detail later on, that what are the things which do not invalidate the fast, because there are a lot of misconceptions among the patients that so and so things are going to invalidate the fast, but we'll talk about them in a minute. As emphasized before, patient must be able to recognize the symptoms of hypo and hyper. Instructions about when they should stop fasting. Instructions to stop fasting. Okay, we have talked about before. Post-Ramadan considerations. The other very, very important thing, I came across some cases where there were dose modifications made in the patient's dosing regimens, and after the Ramadan finished, we found that the patient was still taking those modified doses for the next 2 weeks, because nobody readjusted the doses back to pre-Ramadan ones. So that's something very important to bear in mind, that the patient should go back to the pre-Ramadan doses after the Ramadan is finished. Yeah. Okay, so that's one very important thing, a resource for you about diabetes and Ramadan. So if you can go onto that website, you can find a lot more other useful resources, and they also now have got an app for that. Okay, going back to our case number 1. A 21-year-old university student with type 1 diabetes, 12 years of age. Her HbA1c was 8.9%, so not very well controlled, wants to fast in Ramadan, comes for consultation. She is on glargine 24 units bedtime and Lispro 7 units each meal. So you can see this is basal bolus regimen. So there is one basal long-acting and one mealtime insulin 3 times a day. No DKA in the last 4 years, experienced early AM and early PM hypos. Issues to address. Would you recommend her to fast or not based on the risk stratification we have? So I'm going to give you 1 minute. If you figure out, please write in the comments. The first one we're talking about. Would you recommend her to fast or not? And if you can figure out which category she falls in, whether high risk, moderate risk, or low risk, that would be good as well. Very good, Lim. Yes, she falls in high risk category because mainly because of she has type 1 diabetes for the last 12 years. So she would be recommended not to fast. But as we have discussed that before, that because Muslims take Ramadan as a very important month in religious from the religious point of view, so most of them, even when you advise them not to fast, they end up fasting. So although this patient is a high risk patient and she should be advised not to fast, but if she still insists to fast, she should be given the full education, especially about when to break the fast when she's fasting. So that's what it is. And how would you advise to monitor her glucose? Because she's on basal bolus regimen, so I would advise her to do the 7-point monitoring, which we have seen before. And importantly, how would you adjust the doses of her medication? So let's see if you can figure out how to adjust her basal and bolus. So I'll give you 2 minutes. Please write in the comments how would you modify her basal insulin and how would you modify her bolus? Okay, so I would jump in now. So as you can see, the basal insulin, we said that if the basal insulin is being given once a day, so that dose will be taken with iftar. Okay, so as we said that this dose will be taken, I'm talking about the basal insulin. This dose will be taken with iftar. So it was already being taken in at the night time with bedtime. So we'll move that to after iftar, and we consider reducing that dose maybe to 20 units. But we are reducing this dose as we said that the patient will be monitoring the glucose levels 7 times a day. So that would be adjusted based on that as well. Rapid acting or short acting insulin, the patient is taking Lispro 3 times a day. So so that was 1, 2, 3. So that the afternoon dose will be skipped because the patient is not taking the lunch. The nighttime dose with before iftar, just before iftar, will remain the same, and the suhoor dose will be reduced. The suhoor dose will be reduced by about 25 to 50%. So we might give 4 units, 4 units, 7 units, 7 units of the insulin Lispro. So again, you can see that we have made some changes in the insulin doses, but that's not, as I said before, that's not the end of the story. The patient will be monitoring, and if the patient is having high or low glucose levels, then the patient will be advised to adjust their insulin units based on that. Let's move to case number 2. A 45-year-old female teacher's occupation is important to note. Type 2 diabetes for the last 10 years. She's currently taking Humalog 25, mixed 25, 40 units twice daily. So that's a pre-mixed insulin. Genumet, which is the combination of metformin and sitagliptin, I think. Last HbA1c was 7.6%, BMI 29, also on treatment for hypertension and dyslipidemia. The same questions that based on a stratification, would you advise? Would you? Well done, Winnie. I read your comment. So based on that, would you advise what risk this patient falls in? High risk, moderate risk, or low risk? So I'll give you 1 minute to write in there. Okay, you can use that that algorithm where which I showed you the figure where there were 14 criteria present, and give the score to the patient and then see what category this patient falls in. So well done, those who are giving me the answer that this patient is in high risk category. But again, if this patient, so this patient will be advised not to fast. So, but if this patient still insists to fast, then we will give her the full counseling about monitoring, about all the things which we have discussed so far, about the nutrition, about recognizing the symptoms of hyper and hypo, about when to break fast, about exercise, so all those counseling she would be given, and about the excessive fluid intake as well after iftar. So all those counseling she would be given, and then she would be given when to advise her to monitor glucose. So she can do 7-point monitoring. Alternatively, she can do 2 to 3-point monitoring based on whatever is easier for her. And then comes the adjustment of the doses. Okay, so for this patient, how would you let's first discuss the insulin, and then we'll talk about the the oral meds. So for this patient, she's taking premixed insulin, 40 units in the morning and 40 units at night. How would you adjust the dose for Ramadan? So very good, everybody. We'll reduce not how much, 15 would be maybe to, no, 15 is less than 50, is more than 50% reduction. So as we said that with pre-mixed insulin twice a day, the doses will be shifted. The morning will be the iftar, evening time, and the evening dose will be suhoor in the morning time. So this patient was taking the same number of units, so that shouldn't be a problem. So evening should remain 40, and AM dose will be reduced, and that will be about 20 to 30 units. You can either ask the patient to take 20 or 30, but that's not the end of the story. The patient will be monitoring and make the adjustment based on that. With the oral medication, this patient is taking Genumet twice a day, metformin and the other drug. So this patient will keep taking this twice a day. So there is no dose adjustment required for either of these drugs present in that combination. So just the morning dose will be taken after suhoor, and the evening time dose will be taken after iftar. Let's take another case, a little bit more complicated. A 53-year-old female. She works in office, so that should tell you that she has a sedentary lifestyle, type 2 diabetes since 17 years, HbA1c 8.2%, and BMI is 31, so she's obese. Currently on premixed insulin, 30/70, 40 units in the morning, 20 units in the evening. She also takes metformin twice a day, linagliptin once a day, amlodipine once a day, atorvastatin once a day. She considers iftar an important occasion, regularly hosting family and friends. So that indicates that she does a lot of preparation for when she's finishing the fast. It's like a feast at iftar time. She chose to fast during Ramadan last year, and she reports that she suffers from hypos before noon. Then blood sugar profile is given for the previous month. So the first thing, again, she is in what risk stratification? So I will leave that slide on it. So if you can try and figure out what risk she has, is she's high risk, moderate risk, or low risk? Okay, I have not done this. I will leave that to you. I guess this patient is because of the duration, yeah, since 17 years, and she is on insulin, and she's suffers from hypos as well, so high risk. But as we know from the experience from her experience, that she has fasted the last Ramadan, and she likes to fast and like celebrate in the iftar time. So she would be fasting as well. If she insists to fast, we are going to give her the advice, and all those advice, bear in mind the nutrition advice. I'll talk about the nutrition advice in a minute. So nutrition advice about recognizing the symptoms of hypo and hyper, about monitoring, about when to break the fast, about exercise. So all those Ramadan education and counseling would be given to her. And then with regards to the nutrition, if you look at her glucose levels, so you can see that before that fasting, she has high levels. Lunchtime, she has this levels. Evening time, she has this levels, and bedtime, she has quite a high level at the bedtime. So when I look at this pattern, I assume that maybe she takes something at night, which she takes in the dinner or the nighttime meal. She takes something which increases her bedtime levels quite a lot. So either she would be advised to take the less sugary foods at bedtime, or increase her the evening time dose a little bit, because she tends to eat something in the evening which is increasing her bedtime glucose levels. So that was from her previous experience. What do we do with the insulin dose here now? AM, PM. So pre-Ramadan was 40 and 20. So Ramadan will be, so this will be shifted. So 20, yeah, we'll make that 15, 10 to 15. And this will be 40, right? So the morning dose has moved to the nighttime, and the nighttime dose has moved to the morning and reduced by 25 to 50%. So that will be her pre-mix insulin dose. What do we do with the oral medications? Metformin, she's taking metformin and linagliptin. We would advise keep taking that. Keep taking that. So metformin twice daily. One will be with suhoor and one will be iftar. Linagliptin better to take with we said DPP-4 inhibitors either morning or suhoor time, either morning or iftar time. And then the other ones are the blood pressure and the hyperlipidemia medications. The patient we can take them at the same time after iftar. So it's easier to take the medicines together rather than splitting them at different times. So that's what, so no dose adjustment required, no major dose adjustment required with the oral medications. This patient is not taking any sulfonylurea, so we should not worry about that. The other thing I would do with this patient medications is also because this patient tends to eat something in the evening which seems to be rich in carbs. So I might increase the PM dose to 45 units, but with monitoring. Okay, so now we talk about the hot issue. We have diabetes, we have Ramadan coming up, and we also in COVID-19 pandemic. So how do the COVID-19 pandemic changes the scenario? There is a very useful guidelines which was produced by Diabetes UK and was published last year in April about managing people with diabetes in Ramadan in COVID-19 pandemic. So it has got some very, very useful advice about what diabetic patients should do in the COVID-19 pandemic. And there is not a lot of modification in the medication therapy, but there is a lot of advice on what to do if they start feeling the symptoms of COVID-19 if they are fasting. So management, so this information has been taken from those guidelines, which I have just shown you in the previous slide. It's the management of acute illness, and that includes COVID-19. So what if a diabetic patient is fasting in Ramadan and he she starts feeling the symptoms of COVID-19, what to do? So of course there will be excessive monitoring of the glucose. First of all, the patient will be advised to stop fasting, to break the fast and take some fluids and do the glucose monitoring. Check the ketones, we've talked about that. Ensure adequate hydration. Follow the government advice for mild symptoms of COVID-19, whatever the local advice is, what to do when the patients start feeling the symptoms. Continue diabetes medications, both oral and GLP-1 receptor agonist and insulin. If symptoms of diarrhea and vomiting are there, then continue the fluids. If blood glucose levels are low, then fluids, take the fluids, the sugary fluids, and if the glucose levels are elevated, then take the non-sugary fluids. If symptoms of dehydration are present, stop SGLT2 inhibitor. I would add metformin to that as well. So if there are symptoms of dehydration in that acute illness, then stop SGLT2 inhibitor, stop metformin. If unwell, requiring and the hospital admission is needed, then consider stop metformin. Okay, they include it here. And SGLT2 inhibitors and GLP receptor agonists as well, and continue the other oral medications. Stop AC inhibitors, ARBs as well, and stop NSAID as well, because they can NSAIDs can cause dehydration. So you can see that these are the same sick rules. Same sick day rules are applied here. I will show you in a minute what I mean by sick day rules if you don't know about them. Okay. What doesn't invalidate the fast? Now, so there's some misconceptions around there in diabetic patients that if I do this, my fast is going to be invalidated. So just to reiterate, injecting insulin while fasting does not break the fast. The general principle is that any injection which is non-nutritious, that injection will not break or invalidate the fast. But if there is an injection which has some nutritional value, like vitamins or some other injection which gives or boosts up the patient's energy, then that breaks the fast, that invalidates the fast. So again, the injections which have no nutrition value, which are given for the medication purpose, those injections are allowed while the patient is fasting. The other important point, checking the blood glucose or ketone levels using home testing kits also do not validate the fast. And likewise, giving blood samples for the lab tests also do not break the fast. Vaccinations, including COVID-19 vaccine, also will not going to break the fast, hopefully. So all these things the patient can do while fasting. However, some patients have a lot of concern that whether we should take a COVID-19 vaccine or not while they're fasting. Sometimes they're concerned about the side effect as well. So for those people who are concerned for that, they can schedule for their COVID-19 vaccine after Ramadan, or at evening time, if possible, after iftar. But general recommendation is that any vaccination, including COVID-19 vaccination, will not invalidate the fast. PCR testing, whether nasal swab or oral swab, also do not invalidate the fast, because nothing goes down or the throat or at the level of the throat. So that will also not break the fast. I have mentioned some points here because there is a lot of concerns about SGLT2 inhibitors, and there are some studies done as well about SGLT2 inhibitors in fasting patients during Ramadan. But generally, they're considered to be safe, and no severe side effects were seen patients taking SGLT2 inhibitors while fasting. But just the other things which we have discussed, that if the patient suffers from acute illness or there is a dehydration present as well, stop SGLT2 inhibitor. Okay, sick day rules. So these sick day rules are not specific for the fasting, and they're not specific for the COVID-19 pandemic. These are the general sick day rules which we educate the diabetic patients about. These are the counseling given about the sugars, insulin, carbohydrate, and ketones, but I will focus on the medications. And remember this mnemonic SADMAN, which stands for SGLT2 inhibitors, ACE inhibitors, diuretics, metformin, ARBs, and NSAIDs. So these are generally when the patient, a diabetic patient, is feeling acutely ill. This drug should be stopped. Mainly because they can cause dehydration and can worsen the condition. Make sure the patient recognizes these symptoms. And I think this is all what I have. So please feel free to put in the questions in the comment or the chat box. Thank you very much for listening. Please feel free to write your questions.
Thank you so much, Dr. Majid, for the very informative talk on the management of diabetes during Ramadan. I personally find it very useful for my practice also, and also for teaching. And as mentioned, please feel free to provide further questions. Yeah, you can.
Thank you, Long.
No worry. Thanks.
Somebody asked me in the email that whether the slides will be sent. I think mentioned that before. Yes, I will try and send you the copy of the slides and also some other useful resources.
Probably maybe I'll get the ball rolling, because you did mention about the several diseases. What are patients on dialysis? Are they belongs to the high risk, or are they in the position to fast?
Good question, Along. There's a dialysis patients will definitely fall under high risk category, and they're strongly advised not to fast. So that's simple answer.
Okay. Yeah, I think that's it.
Yeah.
Mm.
I have seen in practice sometimes that there are some patients who are really very complicated patients, and they are insisting to fast. But they need some counseling. For example, you can say to them, because the Quran not only says about fasting, but the Quran also says that do not harm your own body. So if you fast, you are seriously going to harm yourself, and that goes against the teaching of Islam. So if you try and convince them from that point, they understand that.
Yeah, that is very good point. Okay. And also sometimes during the first few days of fasting, the appetite does reduce. In this case, what is your advice? Would they straight away, would they be prone to having hypoglycemic effect if they are using, for example, the adjustments, recommended adjustment?
Very good question, Long. When Ramadan starts and when people start fasting, for everybody, the first few days are really very hard because you're making a lot of changes in your lifestyle and your diet. So the first few days of Ramadan are very hard, and also especially for the diabetic patients. So when I'm talking to the diabetic patients, I strongly advise them to monitor their glucose levels more frequently in the first few days if they can, because that will tell them when they are having hypo or hyper, and we can adjust their dose at that time. So one thing in the first few days of Ramadan, monitor more frequently. Maybe you can reduce the monitoring frequency later on, but more frequently in the first few days, and more hydration after iftar for the first few days, especially because little bit of dehydration every day can accumulate and can result in the acute illness. So if they get into the habit of hydrating themselves right from the start, that would be very useful.
Okay, good point. Thank you. What if, let's say, in the first few days they have this hypoglycemic effect and then they have to break fast early? Would they recommend to continue the fasting for the following days?
Again, very good question. It depends on how severe that patient felt. We have seen that the patients who had less than 70 milligrams per deciliter glucose, for example, 60, and they broke their fast, but they did not feel any symptoms. but they broke their fast, which was fine as per the recommendations. And then from the right from the next day, they were fine, because we figured out that this patient had hypo because maybe they did not eat anything properly in the suhoor time. So we figured that out, and we adjusted the suhoor meal, and this patient started fasting right from the next day. And then we have seen the cases in contrast where the patient almost fainted, but they have hypoglycemia symptoms. And for those patients, we advised not to fast them for the next day, just to see how they feel, and then go on from there. So again, it has to be individualized.
Okay, yeah, okay, thanks. What if they miss the sahur meal? Would they recommend
Ah.
it to, because sometimes they overslept or getting too tired?
Yeah, that also happens. As I mentioned before, strongly, for diabetic patients, they must have suhoor, and as late as possible if they can. But if for any reason they miss their suhoor, my advice for them is that, of course, if they were on insulin, pre-mixed insulin or parenteral insulin, they will skip that insulin as well if they miss suhoor. For the medications, I would advise them to check their glucose levels right in the morning, midday, and the day late afternoon as well. And if they are having very low, less than 70, they should break the fast. I had also advised them to, during fasting, I advise them not to do any vigorous exercise or strenuous physical activity, just in case they might have hypo. So if they feel hypo, break the fast. If not, then continue fasting and do the glucose levels just before iftar as well again. And then take their normal doses with iftar if everything is fine. But yeah, if they miss suhoor, the two key things are do not do any strong or physical exercises, and keep monitoring.
Okay, yeah, very good point. I think the participants are a bit shy. There is no further comments or questions. Probably we will close the session today. Any take-home message or any other advice for those practitioners or patients that come across on this our webinar?
My last takeaway advice would be, because this is the second time now we are having Ramadan in the COVID-19 pandemic. So the last year we were all very confused what to do, but this year now we have some guidelines on our hands about diabetes management in the COVID-19. So when you are managing your diabetic patients in Ramadan, do not forget that we are in the COVID-19 pandemic, and these patients may get the infection during Ramadan while they're fasting, or even their family member might get, and because of that, they might start having symptoms as well. So if they please strongly advise to your patients that if while the fasting they feel the symptoms of COVID-19, they must break their fast. The other takeaway message I would give is that there was a slide about the things which do not invalidate the fast. So there is a lot. I think I've put that up as well again. So there is a lot of misconceptions among the patients about these things that they invalidate the fast, and that's why the patients have these myths. And sometimes the patients get themselves into a more dangerous situation because of these myths. So we should definitely try and explain to them these things, and that these are the myths, and that the fast is still valid even if they do these things. So that's all I have.
Thank you so much. I think because fasting also have been proven is a beneficial effect
Yeah,
for the
definitely.
various conditions, and also practice universal in by other religions also. So definitely with all these tips, I hope that it will be very useful for everyone to have more confidence fasting, especially those who have diabetes like this. thank you again. Thank you once again, Dr. Majid Ali, for the very useful and then talking almost 2 hours. And then
Yes.
we hope we have similar seminars in future. Okay.
Yeah, thank you. Thank you so much, Long. And it was a pleasure talking about diabetes management, Ramadan. I hope you found that useful. If you have got any further questions, please feel free to email us. Thank you very much.
Okay, then. Thank you. See you everyone again.
Yeah,
Just have a very blessed Ramadan.
thank you.